A 44-year-old lady is found to have a gallbladder polyp of 1.2 centimeters in size on routine abdominal ultrasound. She is symptomless and appears to be well otherwise with no complaints. You're asked to comment on the further management of this case. How will you manage the patient? Okay, so the correct answer here is going to be open cholecystectomy. That is what is written in the books. And the reason for that is that if you have a polyp which is more than 1 centimeter in size, the latest Bailey says if it's more than 1 centimeter in size, it carries an increased risk of malignancy and we need to operate, right? So I also have 2 gallbladder polyps. One is 5 millimeters, one is 6 millimeters, but fortunately they've remained the same size since the last 4 years now, okay? And I get every 6 monthly scans done to see the size. And as long as they're stable, I don't need to get surgery done. But if they start increasing or if they reach more than 1 centimeter in size, that's when we need to do a cholecystectomy. Now, the problem is that if we do a lap cholecystectomy and if by mistake there is injury to the bladder and there is bile leak, then we are going to upstage the disease. Which is why some of the books, including Bailey, says that it is better to do an open cholecystectomy if you have a gallbladder polyp. Of course, these days, you can use retrieval bag and you can put the gallbladder in that retrieval bag and you can retrieve it. But as per the books, the classical answer here will be open cholecystectomy. So the correct answer here would be open cholecystectomy. A 57-year-old alcoholic male presents to the clinic with complaints of black stool since the last 1 week. He also says he experiences fullness and the size of his trousers is increased from 36 to 40 inches. Portal hypertension is suspected and hepatic venography is done. Which among the following is the correct equation for hepatic venous pressure gradient? Correct. So the correct answer is A, that is correct, hepatic venous portal gradient. So this is what we measure to see portal hypertension, right? To see the portal hypertension, and a duplex scan can be done and we can measure this value using a duplex scan. And clinically significant portal hypertension is evident when it exceeds more than 10. More than 10, the varices will start to form, and more than 12 millimeters of mercury, the varices start to rupture, right? More than 12, the varices start to rupture. Now, most commonly, the procedure involves placing a balloon catheter into the hepatic vein and measuring the free hepatic venous pressure. And then we deflate the balloon and the wedge hepatic pressure is measured. So hepatic venous pressure gradient is wedge hepatic venous pressure minus the free hepatic venous pressure. That is how we calculate the hepatic portal venous gradient. And you need to remember this. The values have also been asked in the exam. And one question from upper GI hemorrhage or 2 questions are usually asked. Because one more thing which you need to understand is that the surgeons are also performing endoscopies. So upper GI hemorrhage cases can even land up with surgeons, with GI surgeons. So you should know about upper GI hemorrhage very well as well. A 23-year-old shepherd presents to the clinic with abdominal pain for the last 1 month. So the hint they've given here is a shepherd. On examination, a mass is felt in the right hypochondrium, which moves with respiration. On investigation and serology, it suggests that there's a hepatic hydatid cyst, which will be the best investigation to assess the hydatid cyst in this patient. That is correct. So CT is the correct answer. Some students get confused with ultrasound, and the reason why they get confused with ultrasound is because there was an old classification known as the 𝗗𝗿 classification. That is an old classification where the hepatic hydatid cysts were classified using ultrasound. But now the latest WHO classification is based on CT scans. So CT scan is the imaging investigation of choice for hepatic hydatid cysts. You should know about that. For a hepatic hydatid cyst, what will be the first line of treatment for a hepatic hydatid cyst? If it's a solitary hepatic hydatid cyst, what will be the first line of treatment? Yes, absolutely. Shagun, you're absolutely right. You're going to give albendazole. Everything, every intervention will be done under the cover of albendazole. That is absolutely correct. Correct. So it's going to be PAIR. And what is the full form of PAIR? PAIR stands for percutaneous aspiration. Injection and reaspiration. Percutaneous aspiration, injection, and reaspiration. That is correct. So CT is the best imaging modality for hydatid cysts, and you will get this floating membrane sign, or water lily sign is what some people like to call it. And it can detect these cysts with 98% accuracy. And you can even do serology to confirm the diagnosis. So serology can be done to confirm the diagnosis. Maria is a middle-aged lady who comes to the emergency department with central abdominal pain and vomiting. She prefers to sit up as the pain feels worse when lying down. And she reports it that it's also worse in eating. Her pulse rate is 143 per minute. Temperature is 38.2, and an abdominal examination reveals periumbilical bruising and severe tenderness. What is the most likely diagnosis? Right. So let's look at the other causes. So appendicitis, we know, will have periumbilical pain. There's going to be periumbilical pain, and this is going to go to the right iliac fossa. So that is why appendicitis is out. Pyelonephritis, again, you will have pain in the lumbar region. There will be pain in the lumbar region, and there is going to be fever along with it as well. Inflammatory bowel disease, they will give you periods of exacerbation and then settling down. So they'll give you multiple episodes of either loose stools or bloody stools that will be there in the history. Ruptured ovarian follicle, they will give you the menstrual history, right? They will give you the menstrual history, and you can pick up ruptured ovarian follicle. So even by elimination, you could have reached acute pancreatitis, but I think so it's a very straightforward thing where they're telling you that there is pain which is radiating to the back, and you have periumbilical bruising as well. What is this periumbilical bruising known as? Which sign is this known as? Correct. And if there is discoloration in the flanks, what do we call it? Gray Turners. Correct. So Cullen's is periumbilical, and the way I remembered it was C for central, right? You can remember C for central. So around the umbilicus, it is going to be Cullen's, and Gray Turners is in the flank. Gray Turners is discoloration in the flanks, and this is seen in acute hemorrhagic pancreatitis. Seen in hemorrhagic pancreatitis.